stroke subtypes, you know, ischemic infarctions, intracerebral hemorrhage, subarachnoid hemorrhage, and now we have the next problem. My presentation does not move. I have to now. Yes, okay. Now it moves. Okay, yes. You see with subtypes of stroke, and in stroke we have for rehabilitation and long-term services, we had some hard criteria for outcome, like long-term mortality and morbidity, like transition to nursing homes or return to work. And we have many soft criteria like independency in ADL functions, participation in family, vocational and social life, independent walking, independency in ADL, health-related quality of life, and burdens of caregivers. And you know some epidemiological data, you know the risk of a stroke increases with age, but about one quarter till 1/3 of stroke patients are in an age below age of retirement, and this worldwide, and in developing countries is the percentage even higher. And only about 50% of stroke survivors being in work at stroke onset will return to work, and stroke rates are increasing in developing and emerging countries, but now starts to decrease in industrialized countries. But stroke is the most important reason for new dependency upon care in all industrialized countries. This is a model of different phases we have established in Germany since 1995 for a chain of acute treatment and different rehabilitation and long-term services after stroke and in all other neurological diseases. Regarding, it's also very important for reimbursement by federal social health companies and federal social pension insurances. And we have started to establish many guidelines on stroke rehabilitation in combined work between the German Society of Neurology, Society of Neurorehabilitation, Neuropsychology, Research and Treatment in Aphasia, and Neurotraumatology and Clinical Neurorehabilitation. And it's always headed and accompanied by a group of medical scientific societies in Germany. And in this work for guidelines, we had also established a guideline for stroke and return to work together with the German statutory pensions insurances in Germany, abbreviated DRV. And in this guidelines, we have looked for prognostic indicators for the impact of combined medical and vocational rehab programs. And we have also some legal regulations for stepwise return to work or for vocational reintegration programs. And after this, the first version of this guideline had been established and published in 2012, and now we are about to review and re-evaluate, rewrite this guideline. we have since this work, we have seen an increasing interest in research on this topic, even in the industrialized countries, also in emerging countries like South Africa and China. And the last look in PubMed and Embased for this work we had done at the end of 2019, and we had seen about more than 200 publications and more than 40 reviews and meta-analysis. And within it was about 10 reports on medical rehab measures, vocational interventions, qualitative analysis, and interviews with stroke patients and or their employers. In Cochrane, there's no guideline to find. What is relevant on the research and organizational side for return to work after stroke? We have increased our scientific knowledges on prognostic factors. In Germany, we have also got some new laws and regulations for the statutory social health and pension insurances, one on flexibility, one law on flexibility in retirement, the other law on participation, and we have a development for practice and research, and we are about to start a research project for return to work for people with acquired brain lesions, financed by the Federal Ministry of Work and Social Affairs. And we have looked what is done in rehab programs within Germany in stroke patients being in the age of work. And we had in 2018 nearly about 20,000 inpatients and about 4,000 outpatient comprehensive medical rehab measurements in CYD patients, which was financed by the German Federal Statutory Pension Insurances Institutes, and nearly of 20,000 of this comprehensive medical rehab measurements had been in time nearly connected to the acute treatment. We call it AHB in German, Anschlussheilbehandlung. What are now the knowledges about the prognostic factors for RTV in stroke? What was, I will show you the evidence we had 2012 and what has now been added since that. There's in gender, there's a tendency that men will have a little bit better chance for RTV than women. For age, it's the chance decreases with old age or with the age near to the age of retirement, but it's unchanged in nearly all countries. The initial severity does not have any prognostic impact, and this is also unchanged. This knowledge is unchanged in any new studies. Also, the localization of the brain lesion, the site and the lobe, does not have any impact on the prognostic impact for RTV. In the existing symptoms, the most impact came from the cognitive disturbances, and the more cognitive disturbance, the more the worse the chance for RTV, and it's confirmed. This fact is confirmed in nearly all studies. And another fact is also confirmed in nearly all studies, that aphasic syndromes are of worse prognosis. And new studies show that also fatigue problems after stroke have a negative negative prognostic impact. And the same is true for affective disorders like depression and anxiety. But there are still great variations in any research findings on these prognostic factors. Here you see from a study, in a series study, we have participated in 2002 to 2006, and the 5 years follow-up has been performed in 2010 and till 2012. And it shows that the incidence of depression and the incidence of anxiety increases in the 5-year follow-up in nearly all countries, for the 4 European countries which had participated in the study. Another very important thing is, rehabilitation aims to improve ADL functions, and ADL functions have a very high prognostic value for return to work. And the better the ADL functions at admission or at discharge from inpatient or outpatient stroke rehab programs, have a very high impact and positive impact. The better the ADL function, the higher the chance for RTV, and is nearly all new study strongly confirm these findings. And on the other side, the length of stay in stroke rehab programs, respectively the time of sick leave due to stroke, decreases the chance for RTV, and it's also confirmed in nearly all studies in all countries. And what we can derive from the new studies, that a coordinated case management program improves the chance for RTV. On the job side, education and the level of the job are important indicators. The higher the education and the level, the better the chance of return to work. And also what is shown, that the beginners of employer and companies have also prognostic impact. Maybe that a big company has more possibilities for any employees to find a new job within the company and within the employer. Over the time, the rate of RTV increases from 6 months up to 4 years, and because many of the additional programs can help, or case management can help for RTV. And it's very important that a patient has at stroke onset an existing employment, return to the existed employer, to a former employer. It's much better and much more possible than to find a new employer after stroke. And on the personal context factors, we can say that behavioral disturbances decreases the chance. It's also confirmed. The motivation to go back to work is very important. Sometimes financial needs can increase the motivation. Very important is also the personal adaptiveness of the patient, that he can adapt to this, the new circumstances at the workplace. And but the impact of specific vocational interventions remains unclear. Maybe that there are only few studies, maybe that is very different what kind of vocational interventions had been performed. Here you see an own existing network here in the region, combining medical and vocational rehabilitation. It's an outpatient network and an outpatient program. It's at the moment, because of COVID pandemic, it's not running, but normally we have started as an outpatient program with medical rehabilitation for some days in a week, for example, 3 days a week and 2 days at a vocational rehab center, vocational rehab, and when the percentage of the medical rehabilitation decreases, the percentage of the job-related training, vocational rehabilitation increases, and within the running program, the patient returned to his or her real employer in the in the region, and will be consulted with both from both sides, from the medical rehab side as from the vocational rehab side. And we have, as I told at the beginning, we have had some changes in laws and regulations in Germany, especially the federal law on participation and the federal law for flexibility in retirement. And the federal law on participation confirms and the civil rights for participation and on statutory benefits for participation, either medical or vocational. And we have the slogan rehab before invalidity pension. And all people with disabilities has a civil right on participation planning with all statutory institutions involved. And the federal law for flexibility gives an impulse on more flexibility in organizing and combining medical and vocational interventions. And also a participative approach was fixed not about us, without us. In German, nicht über uns, ohne uns. And the German statutory pensions insurances had established an evidence-based therapy modules in stroke rehabilitation, rehabilitation programs they pay for. And these programs are aimed to avoid early retirement after stroke. And from this work in the German pension insurances, two researchers had established a model, the so-called APC model. It relies on the background I had told you in the beginning. And the successful elements are that they include information about job situation. They involve actively the employment side and the employers. We have a German program, it's called BEM, Vocation Employers, Vocational Reintegration Management and it established an individually adapted and coordinated case management. And this is this APC model from the two authors. We have the personal factors, we have the workplace, we have rehabilitation services, and here you see the they need cooperativeness, we need adaptiveness, and we need purposefulness, all aimed for improving return to work for people with acquired brain lesions. And we now, on the basis of this research and model, we are about to start a research project granted by the Federal Ministry for Work and Social Affairs, while the services for inpatient or outpatient post-acute rehab, eligible stroke patients should be identified. They get a rehab plan for their following RTV process, and they will be accompanied by an individually adapted and coordinated case management, which involves all statutory institutions who have to join. And after the discharge from this inpatient or outpatient post-acute stroke rehab, the case manager has to make contact with employer and with the team responsible at the employer and at the company for return to work. And they have to initiate vocational rehab measurements or plan a step-based reintegration at the workplace, and they will follow up the participants till 6 months after definite RTV or vocational reintegration, and they also do a scientific evaluation. And this is this model it will be performed in selected model regions within Germany, the phase of the in or outpatient medical rehabilitation, the phase at the workplace with vocational reintegration programs, and the aftercare phase. And the main new perspective is to integrate an individual case manager, and the time frame for these interventions are till 1 year, 12 months, and by plan 6 months for aftercare. And they combine from the initial German model of phases, the phases D and E. What are the inclusion criteria for this project? It's a German abbreviation. The participant must have an existing workplace and employment. They must stay in a post-acute rehab measurement paid for by the German statutory pension insurances. They have to live in the selected region because of the access to the case management. The rehab goal, the global rehab goal, must be the reintegration to the first job market. Respectively, they must have a positive prognosis for this goal, and they will have a need for professional case management and follow up until the definite job reintegration is reached. And the employer, the company, the workplace officer must be involved in the case management and give an consent to be involved. And from this work, we want to build up a regional based network for RTB. And we also want to record all the needs and benefits for RTB, for vocational reintegration. And we believe that we can increase the rate and time of RTB and vocational reintegration. Some additional projects we plan and do in Germany for increasing the rate of RTB after stroke are to be involved in the guideline on technical aids in neurorehabilitation. It's also on revisioning work, and we have also a guideline on multi-professional team approach in neurorehabilitation. This is at the time also in revision. Now we conclude on RTB in stroke that to make a prognosis for RTB is a complex expert's decision relying on many different factors besides the biomedical aspects. It develops during rehab interventions and with running time. Personal and environmental context factors play an important role. The rate of successful RTB could be significantly improved by case management and involvement of workplace and employer. Regional networks between medical rehab and vocational interventions can additionally help to improve the rate of successful RTB vocational rehab. And on this topic, we will start a research project in Germany. Our own experiences with regional network I have showed you are very promising. But I think stroke rehabilitation, and especially in the younger, will be a big challenge for all of us in the future. And then I thank you for your attention from Germany, Bavaria, and I would bet you for my technical problems. I hope now everything was clear beside the initial technical problems.